Thanks very much, Merle, for that nice introduction. Before my formal remarks, I wanted to make a personal announcement, so bear with me. I want to share something special. I know that there are many patients in the room today, but there's one particular patient who's a very special patient, and she knows who she is. I was hoping that she might stand and be acknowledged. So, our announcement is that we're engaged. We're engaged. Now, when you hear it that way, it takes on a bigger meaning than we've been thinking about in the past. And my hope is that we really think about being engaged in that sense, that we're really engaged with patients and all the things that it means when there is an engagement, and about the planning, and about the trust, and about all of those things that occur when you get engaged. I know that there are some media here today, and one of the things that we talk about with patients is respect for privacy. So I would ask that on behalf of Gail that you keep that little personal announcement a secret. Some of the slides that I'm going to be using today are from work that I did that was funded by PCORI. Some of the slides are my own, but I do want to acknowledge that some of them are based upon the work that I did with PCORI. And so I want to let you know that the views that I'm expressing are my own and do not represent the views of PCORI or their methodology committee necessarily. At the same time, I do want to acknowledge funding that allowed me to continue some of the work that I've been doing over the years. I also have learned after 20 years of teaching that it's best to get the main points out front. So I want to begin by the three things that I want you to remember today. And these are echoing what Merle said a minute ago. The first is that patient engagement really is at every step, And one of the things that came out of the work that we did with PCORI is this concept of pre-engagement, which is a step that sometimes we don't think about. And that is that concept of what happens before a commitment is made to go forward into doing something together, right? And if we think about what it means to get engaged, usually before you get engaged, there's been some experiences that have happened before. And those experiences prepare you for getting engaged. So I would encourage you to think about every step, beginning at that pre-engagement step, going through each of the steps that I'll describe today, and getting to that final step of implementation and dissemination. The second is that in order to do that, as with being engaged, there has to be a level of trust. There has to be a level of trust. And sometimes it sounds like a lot of work to do all of this. But if you think about it, if you're going to get engaged, you should be ready to do what's necessary for there to be trust. And if you're willing to work hard, and if you're willing to work at that trust, you can have meaningful engagement. And the last one is something that's near and dear to my heart as a health disparities researcher. And that is that we can't just engage the patients who are easily accessible, but that if we're going to live up to CER, which includes broad patient populations, that we really need to think about the diversity of patients and make sure that even these patients that are sometimes referred to as hard to reach, that they're part of that. And that we go through every step with them in order to make sure that they're truly engaged, so that at the end we can say that we're engaged. I think if we think about another aspect of research, we think about informed consent. And it's hard to imagine truly engaging individuals, especially some who are harder to reach than others, without really thinking about what it means for them to be informed and consent to that engagement process and experience. And I believe that this concept of pre-engagement helps. Most of you are probably on board with this concept that we want to be patient-centered and beginning to understand why and how we could engage patients. I think it really is important to understand that the reason for engagement is so that the research is meaningful. The reason for engagement of patients is so that that research is meaningful. And we need to think about meaningful to those patients for whom we're producing this information. Part of that is framing the question. And I have found in my own work that no matter how well I think I phrased a question, it still is sometimes difficult for some patients to understand. And yet, if I spend the time to talk with patients and say, well, how would you describe that? Or what do you think the question is that we're answering? It's amazing what I hear when I listen to the voices of patients. And I've had several of my research projects framed by patients, where we've come together, where I've listened to them. Sometimes I even change what I'm going to do because I realize that their question is a better question than my question. And sometimes we share a common research topic, but I understand that the way in which they're phrasing the question is going to be more meaningful to other patients. The other part of this, of course, is that if we are able to answer the question, we want to make sure that that answer is meaningful. And so it's framing the question and also framing the answer so that patients can understand what new evidence exists. Part of that requires framing our questions with cultural competence. This is a lifelong journey, and it's related to this concept of trust. We see around the world that when you're from a different culture, it sometimes is hard to engage. And if we develop cultural competence, it's much easier for us to engage, to understand someone else's culture, and to understand what it means to be willing to understand from their perspective what is the question and what is the answer. And this word meaningful that we all like is a little bit troublesome because we don't quite know what we mean by meaningful. We're going to discuss that today. But I think we want to think about whether meaningful simply means that a patient understands, in other words, it has meaning, or whether it somehow leads to impact, whether it's significant enough that when the patient understands the question and the answer, that patients are motivated to want to do something. Is it that higher level of meaningful that we're seeking? A related concept, I think, is this issue of patient activation. We're starting to hear more and more about patient activation. How is it that a patient becomes activated to want to be involved in understanding their disease, in understanding their treatment options, in understanding what they can do with their healthcare provider to live a healthier life according to their preferences? And that this is part of the reason that we want to engage patients, is we have to understand that concept that's in their minds in order for there to be, in my opinion, meaningful engagement. At the broader level, the nation's health can be improved if we engage patients in a meaningful way in comparative effectiveness research and patient-centered outcomes research. It's the public health of the nation that stands before us and can be improved. And that, to me, is a pretty important reason to engage patients so that we can make the nation healthy. In order to do that, we have to understand the uniqueness of every patient, the breadth of views, the breadth of preferences, the breadth of what is important to patients, which is not the same. We also need to understand some pragmatic considerations. The fact that patients are people, and that the only thing that's going on in their life is not the illness that you're trying to understand, but everything else that affects how they make decisions and how they receive and interpret information. And so we also want to think about these pragmatic considerations when we're engaging patients. Finally, I think there is something about being honest that builds trust faster. And so part of the reason that we want sincere engagement is that honesty will help us to build this support. If that's why, then how? This is the part that sometimes seems scary to people, is we all want to do the right thing, but it seems like an enormous task to really go out there and do what people are asking us to do, to engage diverse patients, to take the time to really listen, especially when there's a deadline. especially when there's a deadline. And what I've learned, and many of us have learned in other aspects of our lives, is if we spend the time up front, it sometimes saves us time. So that we're not spending time trying to interpret something that's not very easily interpretable by patients because we've taken the time up front. And so if we think about the time frame of generating evidence and disseminating it, it may be that we're simply shifting the amount of time that we spend in those early steps so that we can make it up in the later steps. When we meet patients where they are, that sometimes means literally meeting them physically where they are. But any of you who have been in clinical practice or any of you who have been in community-based research know that there's also meeting patients where they are emotionally and in every other aspect of their lives. So it's one thing to come out of the academic ivory tower and into the community physically. It's another thing to have compassion and to understand and to take the time to listen, especially when you have a deadline. And I understand that. And I understand what it's like for a busy clinician who's trying to get to the next patient. And I understand what it's like for a busy researcher who's trying to meet a deadline. But I find that if we take the time to listen, we get to the end just as quickly because we're able to make up time, because we have framed the question correctly, and so it's easier for us to frame the answer. It's also the case that, as with many other things in life, there are people who are willing to help. Sometimes we think we need to do all of this by ourselves. I personally don't try to find all of the patients who are involved in my studies. I reach out to groups that I work with, and through those groups, they engage patients. And they use the trust that they've built with those patients to engage patients in our process. And so I pre-engage with those community partners, and they pre-engage with patients, and then they help to engage the patients, and then those patients are more engaged in our studies. And it is important to understand that there are organizations, and there are leaders, and there are community members who are portals to patients. And getting to know those individuals, not just those institutions, is so critical. One of the things that we did learn from our PCORI-funded contract is this concept of trust, and along with it, what it means to build trust by using simple language. This diagram was redone by our patients and patient advocates who kept telling us that our words were too large. And what we learned is, as we know from community-based participatory research, that research must begin with building trust and maintaining that trust, and that process never ends, and that there are feedback loops. It is about partnering with these patients and their communities to identify opportunities to partner in research, to first identify opportunities. That's part of that pre-engagement. What is it that you would be interested in partnering on, instead of assuming that you're going to be interested in everything that I'm interested in? And then it is about partnering. It is about explaining. We use the term informed consent. That's a nice research word, but explaining and answering questions before we begin. The next I love. We must have spent a half an hour on this one word. We have all these fancy words for implementation and all those words. And they said, it's doing it. It's just doing it. Why do you keep trying to use the big word? It's just doing it. It's like when you get to that point where you're doing it, that's where the trust is so important. If you've done the right things up until that point, then when you do the research, patients are engaged. And then finally, it is updating. And we learned a lot about what it means to update. And I'll talk about that in a couple of minutes. But that's part of trust, which is not just getting what you wanted to get, but bringing back what we want. I truly believe that if we are going to have trust in research, we need a period of pre-engagement. The research nurse at the Safety Net Hospital whom I work with, she's developed this process by which when her patients come in, she won't ask them to participate in a study that day. She'll say to them, Mrs. Jones, Mr. Smith, when you come back next week or next month, I'd like to talk to you about a study that we're about to begin. And she gives them just a few details because she knows that they're going to want to go home and they're going to want to talk with their family. And that if on the same day she explains that research project and asks them to have informed consent that day, that contributes to the dropout rate in prior studies. Because in her mind, that's not really informed consent. Because for a lot of people, an informed consent means being able to think about what they're being asked to do and discuss it with family and loved ones. And so this period of pre-engagement exists between a researcher and the community, but it also exists between a community recruitment site and their patients. And I think this is a great contribution that we've identified that we try to bring into our research now. It's also about making sure that you understand where people are, that you communicate in a way that is engaging. In one of our projects, we learned that this particular patient population in West Baltimore was tired of being asked questions, especially because the questions all started sounding very similar. And last week, the other university in town was in, and their questions kind of sounded the same. And the patients were beginning to wonder, didn't we ever talk to each other? Didn't we ever learn from each other? And what they said is, can you stop asking us questions? Right? And so what we learned from that experience is that sometimes role-playing can get you what you want. Because sometimes people get tired of being asked questions, especially if that portal is a community health clinic where patients go and every time they show up, they're being asked questions. And just for once, they'd like it to be a little bit different. Trust is also about being there. It's about being there. We got engaged. We got engaged. And my partner expects that I'm going to be there. I think that's a reasonable expectation. But I think sometimes we're perceived as not being there 5 minutes after the study ends. Oh, we'll show up again when we have another study. But what about when we're having an event? And it's just, the community's event. Where are the researchers then? We heard a lot about that. What does it mean to be there? So this concept of why and how leads us into when. Well, the answer is always. If you're going to be there, it means being there at the beginning, being there at the end, being there throughout, but also being there in between studies, because that shows a real commitment, and that's part of building trust. And we've been asked, as many of you have, to kind of come back in between studies, just to talk. We were talking a little while ago about healthcare reform. One of the churches that I work with, they asked me if after we did our research project, could I talk with them about what just happened in healthcare reform? And I said, okay. I wasn't sure what the questions were going to be, and some of the questions I couldn't answer. But the questions I couldn't answer, I told them I would get an answer for them. And I could tell that they appreciated that, because they knew that's not why I was there, but that's why they were there. They felt that this was a researcher from a university, and that something big just happened in our country, and that I might have some information that would help them to understand what just happened. I encourage all of us to think about that. Listen to the patients, listen to what they want, be there. We've developed this 10-step process. I think some people argue that maybe one or two of the steps should be tweaked, or maybe we missed one or two steps. But as a general, I think this provides a nice framework for what it means to take comparative effectiveness research and make it patient-centered outcomes research by engaging patients at every step. The first is topic solicitation, and I think the Institute of Medicine really has shown us some good practices for that, to allow everyone to have input into what is important to study. Where are there evidence gaps? There is then a need to prioritize. And it seems that if we're doing this for patients, that patients need to be part of that prioritization process. Once we know what we're studying, getting that question phrased correctly saves so much time in the later steps. And patients are phenomenal for being able to take a complex concept and putting it into easy to understand language. And phrasing a question. So these 3 steps, I think, are quite informative. And we've published this. I've listed the citation there. And we've hinted at some of the methods that might be used, but we haven't really mapped the methods step by step. That's something that we plan to do in the future. But what we do know is that it seems that in the early stages, you'd want to have a broad engagement of stakeholders to make sure that you really do hear about priorities from a large group of individuals. And that maybe in later steps, there needs to be a more consistent working relationship, and so you might use different methods. So we talk about, as we're getting into the conducting of the research, the doing it, as the patients tell us, that we know that patients can help us to think about meaningful comparators and meaningful outcomes. We sometimes think that they can't help us to understand the conceptual framework. That's a research skill. Thinking patients understand what the trajectory is between decisions and health outcomes much better than sometimes we appreciate. So if we want to have a conceptual framework for how things may improve health, we can engage patients in designing our conceptual framework. When it comes time to an analysis plan, it seems that we would want to engage patients. This is something that I've really had to spend some time engaging my fellow researchers on, because they're convinced that to know an analysis plan, well, then you need to really be a researcher. I said, no, not necessarily. Part of that analysis plan may be about understanding what, in statistics we call interaction terms. Right? So a simple example is, we know that an outcome might be associated with gender or race. We also know that it may be associated with age. Sometimes the age trajectory is different in one race than another, or in men than women. And so there's this interaction that the trajectory of age is different in women than in men in terms of outcomes. Right? And that's a researcher term. But if you are talking with patients and you hear why something may be different in one population than another, and you're really listening, you can hear the difference between age is a factor and race is a factor. And something is different in elderly black women than elderly black men. Right? And if you're listening, you're learning about your analysis plan. Right? We were all taught to have a conceptual model before we get into our data. Some of us are quantitative data hogs who forget about the model. But we were all taught we were supposed to have a model, and our patients can help us to develop those models. Data collection. Well, here's one where we think, oh yes, of course patients can help us. We can send them out and they can help us to gather the data. That's true, but there's another way of meaningful engagement, which is asking them what they think would be the best way to gather data, what they think would be the maximum number of minutes or questions that people would be willing to participate in, by asking about how often is reasonable for a patient to report. Right? That's part of data collection too. So there's not just this, can we hire you to do something for us, but will you be an advisor to us to help us think through how to do data collection? And if we've done all of that, when we get to these later stages, it is much easier to engage patients in helping us to think about interpretation, translation, and dissemination, because it's not the first time that the voice of the patient is being heard. The term hard to reach, that was the term that was used in the PCORI contract. And it's meant to be people who traditionally are not engaged in research. It's a term that I struggled with. It didn't quite feel right to me, but I understood it. And I think everyone else understood it. And part of this was about broad patient populations. But we really thought a lot about, what does it mean to be hard to reach? Clearly, this was a hard to reach patient. If you're in the back of the room and you can't quite see this, this is a person who's being put into a helicopter to go receive care from the top of a mountain. And yes, geography is important, and geography does sometimes make patients hard to reach. But there are other patients who are hard to reach and who are underrepresented historically. We know that oftentimes minority patients and patients with impairments are sometimes viewed in that light and not as potential patients. One of the greatest lessons that I heard again during some of our PCORI research was from a gentleman who was blind since birth. And we talked about all the different terms. He chose to call himself blind. He understood why other people use other words. And he said to me, what's most disconcerting to me is, I've been blind since birth. I can't tell you how many vision studies I've been asked to participate in. Never once was I ever recruited into a diabetes study. And he said, that's what concerns me. I've been blind since birth, so I know how to deal with that. I cannot manage my diabetes on a day-to-day basis. I thought, wow, right. You come into an office every day and people know you have diabetes, but they don't see you as a diabetes patient because they see you differently. And so it's letting a patient define who they are. What we learned was that patients do define hard to reach by some impairments or illnesses that people have, or the age of a patient, or where a patient lives. And where a patient lives, there's a lot of definitions about that. So it can be far away, or it can be in a community where researchers don't feel comfortable going to collect data. And people are aware of that. It's also about social indicators and what they do. Now, in polite conversation, when somebody says, what do you do? Many of you respond by telling your profession. But in the broader society, what you do is not just about your job. And if we think about how people identify with what they do, and that there are certain things that people do that put them in a pocket of society where we don't engage them frequently, they're aware of the fact that they're not being engaged, and that sends a message. We learned from the mayor of the block. We had a couple mayors of the block in our PCORI-funded study. And what was interesting is I was presenting this once with another academic institution who had just done a phenomenal work on very similar research. And they had just stood up and finished, and they were talking about how they engaged the PTA at the schools, and it was just great conversation. And so I say to people that, yeah, the head of the PTA, that's one mayor of the block. In West Baltimore, the mayor of the block is a very different person. It may be a person who's been in trouble with the law over the years, and who finally got their act together, and who wants so desperately to help young people not go through what they went through, not get into the aspects of mental health that they went through, or physical health. And that those mayors of the block can help you to get to hard-to-reach patients. We also learned that every organization is a potential organization to partner with, because they have individuals who probably want to share their story. People who are in clinical practice understand this concept of not using jargon. For some reason, when we go back into research, we start doing it again. And so we were reminded of this concept of using plain language, not jargon. We were reminded that maybe research should be similar to clinical practice, and we should use the teach-back method. The teach-back method is, if I'm a patient and my clinician has told me what I'm supposed to do or something, they ask me, so, given our discussion, what do you understand is affecting your condition today? Or given our conversation, how would you take the medicine that I've just prescribed to you? And then listening to what the patient says to make sure that they understood it. We don't always do that in research, and I thought that was a great thing that we learned, especially when you're dealing with hard-to-reach individuals. And then finally, there's this question that I think we always need to ask ourselves, and that is, if we're talking about somebody who's hard to reach, they may find us hard to reach too. And so what's going on, and who's really hard to reach? The last couple slides are some of the findings from our PCORI work. It's an ethical dilemma to think about research and using that term, because we feel that we need to make sure that through informed consent, people understand that this is a research study. But the minute that some people hear research, it conjures up something that probably leads to misinformation. Some people, the minute they hear research, assume that something bad is going to happen. And some people, when they hear research, assume that something good is going to happen. And neither of those are true. Neither of those are true. It's not necessarily true that if you participate in research that something bad is going to happen, but it's also not necessarily true that if you participate in research that something good is going to happen. And many patients, especially hard-to-reach patients, think that you basically promise them better care. And so we need to make sure that people understand that. And sometimes, words help, and sometimes they get in the way. It helps if we've experienced this concept of pre-engagement, where patients are educated on what research is before they start participating in research. The community sites understand what research is before they start participating in it. It also allows time for people to really think and make a conscious decision, make a commitment to be engaged. Because if we rush people into a commitment, right, they may not really be engaged. If I said to you at the beginning that we're sort of engaged, sounds a little different, right? We don't want people to be sort of engaged. We want people to be engaged. I spent some time talking about trust and what we learn from trust. It's clearly an important factor. Any of you who have been involved in community research, you know that trust takes a long time to build, but takes a nanosecond to go away. You can also recover from that nanosecond and rebuild. But this concept of trust building with community partners and with individual providers and individual patients, is a continuous process. We are more engaged when we trust each other. Part of that is respecting privacy. As I mentioned earlier, patients like to know that their privacy will be respected. And there are sometimes certain topics in certain communities or certain families that are just not to be discussed. And part of trust and respect is understanding and respecting that there are certain topics that one just doesn't discuss. It's also about understanding whether people want you to come to them or whether they want to come to you. Some people like to meet in a public place. They don't want you coming to their house. They don't want to have to explain to their neighbors why somebody was at their door yesterday. Some people want you to come to them. Maybe because they can't come to you, or maybe because that's part of showing trust, that's showing that you respect them enough that you're willing to come and meet them where they are. And so it's understanding these issues and listening and making the commitment that we really do want full spectrum participation and that requires full spectrum recruitment. And that sometimes it is harder to reach some individuals, but if we want all of the outcomes that are meaningful to patients and we want broad patient populations, that we need to then respect, the need to have full spectrum participation. The last component is this concept of giving back, which is related to being there. And we learned a lot from talking to some of our hard-to-reach populations about what it means to give back. Because most of us think it's making sure that we have a lay language version of the abstract. And that's part of it. That is definitely part of it, and I encourage everyone to do that with every study. But sometimes giving back is just keeping in touch. Some of the patients were great, and they said, sometimes I just want to know, was I the only person in your study? How hard is it for us to tell people, no, you're not. In fact, we've had 300 patients enrolled, and we expect that next month we'll have completed enrollment. We give our sponsors those updates. That's not going to mess up the research integrity of our studies. If people say, oh, you can't give feedback to patients while a study is going on, that'll mess up the research integrity. How does my knowing that there's 300 versus 30 patients enrolled mess up the research integrity of a study? Maybe I'm not getting that. Maybe I need to listen to the voice of researchers who understand that better. But it seems to me like that's something we can give, or at least make it available on our website so that people would know. Sometimes giving back means coming back to answer questions that they want. The number of times I've been asked, you're on that campus. Don't you have some physicians, nurses, pharmacists, lawyers who can come and talk to us some Sunday? And I'd like to think that, yes, there are some who would be willing to come to talk to you on Sunday. Not about our research, but about what's important to you. And I think that's part of giving back and being there, in the way in which we develop sustainable partnerships in research. Giving back. Isn't that what's expected when you get engaged? Thank you.